Shall we begin?
Yes, sir.
Okay. So once again, I welcome all the participants to this virtual learning platform where we talk, discuss, conduct the webinars and open experience sharing. So this is the 11th episode on adolescent mental health, a global perspective. For the convener for this program is Dr. Manisha Kiran, who is Associate Professor and Head of Department of PSW. We have with us a very eminent speaker, Dr. Rushi, who is Associate Professor and Head of the Department of Clinical Psychology at Dr. RML Hospital, New Delhi and ABVIMS. She has a very vast experience of 17 years working on this area. Particularly on various aspects of mental health and interventions to the larger community. So then again we have a very eminent speaker, Miss Priya Mary Abraham, who is the former School of Social Worker, particularly from Ottawa, and she has also done her MPhil and PhD from RINPAS. So she, in a way, she is a very known alumni to, or right now, Dr. Manji also said that both of them are, had a very long association as they were, with us on RINPAS for, their training programs. So, without taking much further time, I welcome once again to the eminent speaker to this particular very relevant topic, adolescent mental health, and particularly looking at a global perspective, what is this mental health mean and how it can be useful for all of us who are working in a way to deliver the mental health services at a society at large. So I welcome once again Dr. Rushi and Miss Priya. And today what we have is the time slot is 20 minutes of presentation, and then we can have a more time on discussion and interaction and experience sharing. So without taking much time, I welcome and I call the first speaker, Dr. Rushi, to begin with her presentation. So, ma'am, there will be a 20-minute presentation time, and then we can have a discussion.
So, good evening, everyone.
Sorry, it
really
is
my privilege to be a part of this program, and it's really my honor also that I have been invited by my
all the speakers are all the participants are to mute their mic, please. Otherwise, it is echoing.
Vikas is there.
Yes, ma'am.
Vikas, have you downloaded my
Yes.
presentation?
Yes, ma'am.
Okay.
Yes, ma'am.
So, thanks everyone. Thanks. I would like to pay my gratitude and thanks to Department of Psychiatric Social Work RINPAS who have invited me. And it's really an opportunity to meet all old friends, my classmates, batchmates, my seniors, my teachers. So thanks a lot. So I'm also very glad to. Is there any problem in the mic?
Yeah,
Yeah, there is an echo, ma'am. There is an echo.
So anyway,
please ask all the participants.
Why we are talking about adolescent mental health is because adolescents are the most important asset of any country and the most important human resource of overall development. And they are the future nation builders. So why we are talking about adolescence? Because it's a very vulnerable age and it's a period between childhood to adulthood. So that is the reason that it's a critical period. It is a state of charm, talent, and fear. Sudden upsurge, adult-like sexual drive suddenly emerge, and there is a very strong need to gain independence. Heightened irritability and sensitivity. There is withdrawal from someone of the emotional ties which were developed in the childhood with the parents. And this is a stage, when the peer relationship becomes important. So that is the reason that the parents, most of the time, they're very much surprised that, what happened to our child. What happened to this adolescent in childhood?
Ma'am, sorry to interrupt, ma'am. Voice is not clear. It's there is very much echo. Can you take care that?
Let me check it. Let me check. Just a minute.
I think there are two involved. I think there are two involved. Somebody is
Rushi, are you using two gadgets?
Somebody is using two instruments in the same room. I think they need to switch one off.
Is it okay now?
Yeah. Now it is okay.
Is it okay?
It is okay
Now it is
Yes. Yes. Yes.
Okay. Actually, I was trying to connect with my laptop also, so probably that was the reason that there was so much of echo. Anyway,
Yeah, that's right.
so there are very strong needs of, need for independence, need for autonomy. So parents are very much worried that, what is happening to the child in this adolescence age. Suddenly there is a quite deviation from that intimacy from the parents. They withdraw themselves from those previously emotional ties which they developed with their parents in the childhood. And suddenly what happened that the peer relationships become increasingly important. So there are feelings of emptiness, feelings of loneliness, boredom, unreality. All these feelings follow if the peer relationships are not substituted for the previously very strong parental relationships which get developed. So peer acceptance is vitally important for adolescents, and peer pressure can lead sometimes to acting out behavior. So they want to experiment with sex, they want to experiment with drugs, and so many other, which are so-called attractive antisocial activities. They're very much attracted towards peer. So how an adolescent fares from this transition to adulthood has long-term repercussions. So that is the reason that we should pay a lot of, attention to this stage. And because school problems during adolescent years may be the result of this rebellion and the need for independence. So many of the time, when we interact with teachers or the parents, they are not able to understand that why the adolescent has suddenly changed. It is because of the struggle he is making in this stage, because it's a very crucial and vulnerable stage. And that is the reason that results in a rebellion and a need for independence. So that is the reason that the parents and the teachers, they play a very important role in providing the information and advice to adolescents and how they can handle themselves, and they can play, they can deal effectively in their environment. So next slide, please. Like I have said that it's a period of transition from, next slide, next. So it's a period from transition from childhood to adulthood. And if you will look at the meaning of adolescence, then it has been taken from the Latin word adolescent, which means to grow and to mature. So the adolescent is making lot of efforts in this sphere because there are all the things, everything is happening all at once. So there are rapid psychological changes, emotional changes, psychological changes, there is educational development, social maturation is occurring, and rapid biological changes occur. So there are a lot of hormonal changes. That is the reason that they behave quite, sometimes they behave in a very awkward way. They show their mood swings, they show irritability. And this is the result of the onset of their puberty, basically. And there are a lot of cognitive changes which occur in this stage because of the emergence of more advanced cognitive abilities. And of course, emotional changes like, self-image, self-concept is developing. They become very intimate with other people in their environment, with their peer group. And there are, of course, social changes because there is a transition into a new role into the society. Next slide, please. Next. So what happened that we should pay attention, we should be focused upon their emotional changes like transition, their fantasy, their attraction towards the opposite gender, their mood swings, and search for when they search for their identity. So these are some of the important, emotional changes which are occurring. And if we pay as a teacher, as a parent, or as a society, if we pay attention to all these, rapid changes which are occurring in the adolescence, they can reach to, good, uh, they can grow into a very healthy personality. And another reason that why we are, next slide, why we are focusing on adolescents is because adolescents represent 1/5 of the world's population. So there are over 1 billion of adolescents in the world. And the next slide is depicting the prevalence of the child and adolescent mental health disorders in certain countries. And, I think Priya will also highlight a global perspective in terms of the prevalence. So I will not go into the detail of this. But 21% of children and adolescents in US meet the diagnostic criteria of mental health disorder with impaired functioning. It has seen, research shows that, and 16% of the children and adolescents in US have impaired mental health functioning and they do not meet criteria of the disorder. So, there are a lot of subsyndromal mental health issues are there. So we can't say that because, the Indian data is depicting that there is almost 12 to 13% of prevalence rate among children and adolescents. But broadly, if you will see that, every second or the third child is having mental health issues. So they're all over the world, you can see there are a lot of subsyndromal mental health issues which need to be addressed. And 50% of the adults in US with mental health disorders had symptoms by the age of 14 years. And this figure is, I'll come to the Indian data also, this figure is very much close to the Indian data. Why? Because in India also it has seen that mood disorder, psychosis, or conduct disorder, there are a lot of depression, anxiety, there are a lot of mental health issues which emerge in adolescence. So that is the reason that, there is need to pay a lot of, attention to the mental health issues during the adolescence. So in India, children and adolescents constitute 40 to 44% over 1 million population. And there is almost 10 to 12% of adolescents below the age of 18 years who suffer from disorders of behavior, learning, and development. And there is a study by ICMR 2001, which shows that 12.8% of children and adolescents suffer from mental and behavioral disorders. So there in India, there is always underreporting, like I have said. So we should not go by this figure, which has been depicted by the ICMR study, right? And there is also one more report in 2001 by World Health Organization, which shows that which shows the estimates of global burden of serious emotional disturbances in children and adolescents up to 15%. So documented mental health issues have been reported from 12 to 20% almost in various different studies. There is a report released by WHO 2017 on mental health of adolescents in India, which highlights that 7% of adolescents were found to be bullied and they felt disturbed due to the comments of their peers, family members, and teachers. 25% of the adolescents were depressed and sad or hopeless, while 11% were distracted and had a very hard time, because they were not able to focus on their work most of the time because of the attention issue. 8% of adolescents were faced anxiety and worry. They were having a lot of sleep problems. The common disorders in age group of 12 to 16 years of adolescents were found to be psychosis, anxiety, depression, and conduct disorders. So it has been stated by WHO 2016 that nearly 20% of children and adolescents suffer from a disabling mental health issues and mental illness. Suicide rates in Indian adolescents appear to be several-fold higher than anywhere else in the world. It accounts for 25% of deaths in boys and 50 to 75% of deaths in girls between the age range of 10 to 9. Very selfish. As per the National Mental Health Survey 2017, the most common disorders, like we have discussed, were anxiety, mood disorder, psychosis. And according to this statistics, over past 3 years, more than 26,000 students have committed suicide across India. Majority of student suicides were caused by underlying psychiatric factors such as stress, depression, anxiety. So, this underlying, stress or anxiety or depression, this is very much common and prevalent in school-going children. The only problem is that the kids, they never go to a mental health professional for their problem. They never access to these services like adults. Like that, if we have any issue, if we are feeling anxious or we are having any depressive symptoms, we always want to contact a professional. And there are in India, health-seeking behavior in adults also is reported to be about 80%. So there is only 20% of people who, go forward for treatment. But in other countries and in India as well, if you will talk about the kids for their, health-seeking behavior, they will never go to a health professional. What happened that they have always been referred by their teachers or by their parents or any authority figure. For what purpose? They never refer those kids to mental health professionals or health professionals for their stress issues or their psychological issues, for anxiety or depression. Why they refer? They only refer for their, antisocial traits. If they are having some conduct issues, they are having behavioral issues. Either the child is not able to focus in studies, he is performing poor in the class, or he is disturbing other kids, or he has become very violent or irritable. So basically, externalizing problems, if they are very much, noticed by the teachers, then only they refer the adolescent to the health professional. But what happened that internalized issues like anxiety and depression and any other psychological issue, they don't go for any, psychiatric or psychological help. So that is also probably one of the reasons that why the mental health disorders are underreported among adolescents in India and in other countries as well. So it could be the result of difficulty in coping with their academics, their unrealistic expectations and pressures from the parents, and lack of support from the peers. So, the unrealistic expectations from the parents and the lack of support from the peers. These two things are very important, and I'll come to my own research data also later in the slide. Where in our research also we found the same problems which can very easily be avoided by the parents and by the teachers or by the other people in the society. But ironically, this is very disappointing that most of the adolescents, they report all the time, they report all these kinds of things. And yes, mostly they have problem in their coping with their academics. So this is very important to focus that it's not that, they are having problems in their academics because of their low IQ or because of specific learning disability only. It is also because they are not being able to get adjust with others. Their coping skills are poor. So that's how, if we know the reason, then only we can target the intervention all over the country. So as per WHO 2017 report, more than 56 million individuals face depressive symptoms. So this is a very high figure which was reported in Mann Ki Baat. And every hour, one student commits suicide in India, with about 28 such suicides reported every day, according to the data compiled by the National Crime Record Bureau. And this NCRB data shows that 10,159 students died by suicide in 2018, where there was an increase from 9,000 to 905 in 2007 and 9,000 478 in 2016. So you see there is an increase in the suicide rates also. So as per the data from the Department of Higher Education under the Ministry of Human Resource and Development, 27 students across 54 Indian Institutes of Technology, I mean IIT, committed suicide between 2014 to 2000. I don't think that it's an alarming figure. All the day, every day we just read or listen to these kind of news about the suicide rates in India. So India has one of the highest suicide rates worldwide, second leading cause of death among the young people, which originates in childhood, greatest risk at adolescence. 90% of diagnosable psychiatric illnesses, usually depression and hopelessness, are the strongest predictors of suicide. And almost there is no intervention for suicide or depression, which we have seen in different kinds of schools. So they have not been targeted for as a part of, with the intention to manage it in the school. And why should we address mental health in schools? Why? Because we are talking about adolescents, right? So why we are talking about that, these intervention strategies or the promotion of mental health or the prevention of suicide or depression or psychiatric disorders should be addressed in schools, because school constitutes a large part of an adolescent. Next slide, please. So promoting mental health and well-being at schools may contribute to better behavior, better health outcomes, and better academic achievement. School can reveal adolescents' personal problems like anxiety, phobia, or depression very easily, but it may equally create big challenges for the adolescents if they are not being recognized by the teachers or the parents at this stage. So schools are one of the settings outside the home where adolescents can acquire new knowledge and skills to grow into a productive and capable citizen who can involve support and help their communities to grow and prosper. Schools have most influential impact on the long-term influence of their cognitive, social, emotional, and behavioral development. So school provides a canvas in the resources. It can be the activities, and the health from school is a setting basically where health programs are promoted, and which in turn can promote to good learning. So there are some challenges in the 21st century. Next slide. Like there is a challenge of child safety, like cyberbullying, bullying, sexual exploitation, or threat assessment, child abuse, violence, behavioral addiction or internet addiction, substance abuse, parenting, and of course emotional and behavioral issues. So these are some of the challenges in the adolescence which we are going to cover, we are going to address in the next slide. Before that, I'll just give a brief account of the research which what I was talking about. That because I have been associated with the Institute of Human Behavior and Life Sciences, Government Medical College, Chandigarh, National Institute of Mental Handicap, and of course, currently I'm working as head of Department Clinical Psychology. Atal Bihari Vajpayee Institute of Medical Sciences, RML Hospital. So, in all these organizations, I have been associated with some school mental health programs. So, we were dealing with children and adolescent mental health. So, we have conducted various workshops with the teachers in the schools, with the parents, and sometimes we have conducted workshops together with the teachers, parents, and schools. And there were very interesting findings which were reported by the adolescents, and they were which was quite alarming also. And various CRE workshops, CRE programs have been conducted with the clinical psychologists or special educators or counselors. And based on the deficits, based on the need of the hour, we have developed certain modules also. I'm not going to cover those modules in this, the current talk. Maybe later on, if in future we will have some time for interaction, then we can highlight those modules, because like we had developed mindfulness modules. So what happened that in UK or US, mindfulness program is a part of the curriculum in school going children. So we had conducted a research and certain dissertation has also been done in this mindfulness training program for adolescents where 9th, 10th, 11th and 12th students were taken from different schools in Delhi. And that mindfulness module was, demonstrated or implemented on that and field tested, and there were very interesting findings which came out. I'll if we will have time later on, then I'll go into the details of it in the later part. So in those workshops, the problems reported by the children in the workshops were that they said that there is constant scolding by the teachers. They have been ridiculed by other children. So this, bullying, the ridicule, what they are reporting, and the bullying behavior, this is very common. And in our child guidance clinics also, what we have seen that most of the time, in nearly 90% of the cases, they report that one or the other time, yes. Okay. So they have reported that one or the other time they have been ridiculed or they have been bullied by some kids in their class. And they say that they have been there is rejection and neglect by the parents. So this is also very important to know and to address that children or the adolescent, they themselves report this thing that rejection and neglect is very common. So somehow they are feeling this neglect and rejection by their parents, by their teachers as well, and the lack of an comparison of their performance with other kids, and then constant fear of being unsuccessful, then punishment by the teachers. They become very apprehensive because of those punishment strategies. And they also reported that they had tensions at home. So the home atmosphere again is very important for the mental well-being of a child. Then constant fights among the parents. So all these things have been reported by the adolescents, that there have been constant fights among the parents, and there is abuse at home or school, there is neglect by the teachers, like they were reporting about the parents, and definitely there are attentional problems. So some programs should be focused on to enhance their attention and concentration, where mindfulness training program is one such very, very, very good or relevant program to enhance the attention and concentration of it, which obviously enhance the, help them in better academic performance. So problems reported by the parents were technological advancements, increasing pressure in the children to achieve, rapidly changing socio-cultural paradigm, and rise in their behavioral issues. So similar kind of problems were also reported by the teachers. So teachers basically reported majorly emotional and behavioral. So teachers and parents were trained to help adolescents in removing their false beliefs about sex, which put them at higher risk for sexually transmitted diseases and teenage pregnancy. And adolescents were also provided with proper sex education in an effective manner, both in school and at their home. So substance abuse was again very important and very important area which should be focused and addressed in adolescents. And it has been reported by the parents as well as by the teachers that they said that in class from class 7 to class 12 they were reporting that almost there was variability, but in some of the schools they said that almost 70% of the kids, 70% of the adolescents, they are indulged in smoking or having one or other kind of substance. To avoid this problem, then we had conducted certain workshops also with teachers and parents, and they were trained to provide proper guidance to adolescents. And they were also told to create a conducive environment to channelize their energy, and which can help them in coping with their stress. So stress management program was also important, because anyway, if you will look at the root cause of substance abuse among adolescents, so mostly it is because of the peer pressure, and sometimes also it is because of it is a part of their unhealthy coping. So again, there is role of life skill training program, because they only with life skill training program, they can focus on the healthy coping strategy. And the reasons were found: lack of proper guidance from the teachers and the parents. So, inappropriate effect of media, wrong association in peer groups, and nervousness towards physical changes, faulty perception towards sex instincts and mood swings. So, if you will look at the root cause, so there is need to spread awareness. So, awareness programs or education programs were very important, which should be, and for that, teachers and parents both can be sensitized by organizing some workshops in the school. And the best way to do that during the teacher-parent meeting. So, in some schools, in every 3 months, they are having those meetings. So if we can plan some, that like what was our plan that we used to organize workshops at least 4 times. That was a mandatory part, 4 times in a year, when there used to be teacher parent meetings, and there used to be different groups which used to target each and every class. So there is not only one team who can deliver or who can psycho-educate teachers, parents. And child safety again is an important area which should be a shared concern of everyone in the community, like parents, educators, healthcare professionals, mental health professionals, and of course law enforcement. Preventing and responding to violence, exploitation, and abuse in adolescents should also be focused. And it has seen that like globalization and urbanization, digitalization has already so it has changed the overall overview, lifestyle, and outlook of the adolescent. Children spend more time online nowadays, and which has been reported by the teachers, by the parents, or by the caregivers. So cyberbullying and bullying is again another important area which should be targeted and which should be addressed for the mental health of adolescents, and that can well be addressed in the schools as well. Then internet addiction and other behavioral addictions, where teachers or the parents can be sensitized about different behavioral or the physical symptoms of addiction, like if the kids are losing track of time when they are online, or they are feeling isolated from their family or friends, they are in trouble in completing their tasks. These are some of the problems which have been often reported by the parents, especially after COVID-19, when kids are not attending the school formally. I mean, they are just doing the online classes. So anyway, their mental health issues are emerging. It is progressing because there is no structure in the life. They are not able to live their normal life which they were living previously before the pandemic. So nowadays, what we have noticed that most of the parents they are reporting this addiction, internet addiction, mobile addiction, very significant. And they should also be very mindful to some of the physical symptoms also. So if there's dryness of eyes, or if there are sleep issues, or the child is reporting fatigue, and what can be done? Then implementation and enforcement of laws, safe environment, education and life skills, teaching about safety online and online, talking about behavioral addiction at home and at school, then helping child to keep identity private, and informing the child where to report. This is also very important. And these are some of the tips for the parents and the caregivers which can be provided, that be proactive, block sites using a firewall, knowing who your child interacts with. That is very important. And set rules for using internet, educate them early about privacy, know and enforce age-appropriate online experiences. And very important is be a role model. Enforce family time without technology. So what happens that, we talk a lot about their mental health issues. We talk a lot about, these mental health issues because of the behavioral addictions or internet addictions. And we do criticize them a lot because of these addictions. But as an adult, what we are doing as a part of this society, what is our responsibility? Are we the role model for these children? No. What happens that, we just make rules for our kids, but we are not able to, or for our kids or adolescents in the family or in the schools, but we are not able to enforce those rules to us. So this is very important that whether it is a family or a school or a college, to stop this thing, we have to be the role model for the adolescents. So the role of educators in this is very important. And another thing is neglect. A lot of adolescents, they report neglect in schools or in colleges or in the families by their parents or the teachers or peer groups. So the most common type of maltreatment is neglect. It doesn't apply living in poverty, but involves caregiver inattention to the basic needs of the child, such as food, clothing, emotional comfort. So this is very important that, if we are fulfilling just the basic needs of the adolescents, that is food, clothing, it's not not enough. Nowadays, because of the, urbanization, globalization, living in a technological world, what is happening that we are not able to provide adequate time to our kids at home. So that is also one of the problem among them. They are not getting that emotional support from the parents. They are not getting that emotional support anywhere. So they feel neglected. So from developmentally, so that is also one of the important areas. How much time I have? Uh, I think I have 15 minutes more now.
Hello, ma'am. I think we are running out of time. So if you can conclude in a very informative session, ma'am.
Sure.
Yeah, please
I will
conclude.
just conclude because I think there is lot of tangentiality in my presentation. So recognizing child abuse and neglect or recognizing the adolescent abuse is very important. And every form of maltreatment which is inflicted on the school or college going children and adolescents, there should be focus and we should be vigilant about that. So threat assessment is all again is an important thing which we should focus. And threat is an expression of intent to do harm or act out violently against someone or something. It is very commonly reported nowadays in the schools, which we should also be mindful to that also. And once a threat is made, having a fair, rational, and standardized treatment or method of evaluating and responding is critically important. So next, I have just come forward, so you can move forward in the slide also. So role of school and educators in promotion of mental health of the adolescents is very important, where the life skill training, socialization skills, problem solving and coping skills, self-protection training, communication skills, awareness programs for the kids and for the parents, anti-bullying efforts, and help families to spend some time, with their adolescents and kids, expression of needs. All these programs should be focused in the school. So school-based community mental health programs should be, should give emphasis, where the training and the training of the staff is very important. Promotion of psychological assessment in school should also be focused. And there should be collaboration with the school service agencies, mental health professionals, social workers, and life coaches. And definitely school-based intervention like easy accessibility to the youth, less stigmatizing, feasible, and acceptable. And if we focus on those school-based interventions, we have seen though the universal intervention, those provided to the general population regardless of the risk, have better acceptance and known for small effect sizes. And indicated programs have been found to have larger effect sizes than the universal programs and be more cost-effective, practical, and beneficial in the long run. So, a lot of emphasis mental illness of children. Teachers should be trained to provide adolescents and children with good reasons to postpone early adult-like sexual drive by focusing and expanding their educational, vocational, and employment opportunities. And teachers and parents should be trained to respond by offering support environment while at the same time providing ample guidance and control. Adolescents and children allowed to exercise their increasing autonomy in mature and responsible fashion. And of course, behavioral modification programs are again important and useful for various emotional and behavioral issues among the adolescents. And a lot of emphasis should be given on the lifestyle, parenting, and the family, of course. And we should also give emphasis on the, direct or indirect interaction between the parents and the children. So marital relationship is very important because that leads to positive parenting, and positive parenting leads to better adolescent behaviors and development. So I will not go into the detail of the parenting. Simply, I will come to that because in childhood, it will say in childhood, what happens that ASD, autism spectrum disorder, ADHD, anxiety, depression. This is very common, but in adolescence, we have seen, or the research research says, there are evidence-based studies which shows that there are significant mental and behavioral issues among adolescents as well. There are issues related to attention and concentration, and schizophrenia, bipolar affective disorder, depression, anxiety, and panic. Again, they are common among children. So, school can be a great location for mental health promotion, early identification, and intervention. If we talk about Delhi experience, there are over 2,000 schools and only 10% of schools have in-house counselors. So again, there is need for more human resource so that we can empower the students and the teachers in those mental health awareness programs. What is needed to create mental health integration in school is surprisingly very little. We need policies and plans that recognize integration of mental health into educational institutions. We need to develop and implement mental health curriculum. We need to train teachers to understand and recognize mental health problems in students during the adolescence period. We need to develop region-specific infrastructure and support. So schools are also great locations for combating stigma associated with mental illness. And integrating mental health education in schools may help stigmatize, or to decrease the mental health issues or mental illness. So I will just conclude by in the last that and which is also a part of most of the schools in metropolitans in India and in various states, that now CBSE board has made this life skill training program mandatory in school. And apart from the capacity building program among the teachers, if we focus on the life skill training program among the adolescents, that can reduce to various health problems among the adolescents, like sexual and reproductive health problems, nutritional problems, substance abuse, mental health problems, accidental and intentional violence. And there are so many things which can be dealt with. And these are basically abilities for adaptive and positive behavior, which help individual or adolescents to deal effectively with their demands and challenges of everyday life. So promotion of course, mental health is an important aspect. Negotiation skills like managing feelings or emotions, like emotion regulation or advocacy skills, or to cope up with the family pressure or peer pressure, And if we can impart social skills like interpersonal relationships, communication skills, or we are focusing or giving emphasis to teamwork, empathy building, and then of course thinking skills में आ जाता है like self awareness skills, problem solving and decision making, critical thinking and creative thinking. Helpful in the prevention of mental illness. So, I'll not go into the detail of this life skill training program or happiness program which are going around different schools. I will just conclude by saying that preventive intervention can postpone, reduce the risk of developing mental health problems. So there is need for systematic methods of carrying out culturally relevant intervention models and test the validity in the community as well as long-term efficacy. And we should give more emphasis to the to those programs which are helpful in the promotion. And so let's move together to make our country or our nation secure and knowledgeable. That is the just last thing I wanted to focus. And rest of the things I think we can discuss in the discussion part. So we are lagging behind the time, and probably the second speaker must be waiting for her presentation. So thank you very much. If you have any query or any question, you can ask now also, or as the moderator says, we can handle that at the end of the session. Thank you very much.
Yeah, thank you very much, ma'am, for a very informative session. And we have got very nice responses on this. But however, we are running short of time. I will take the question answers following the next presentation, because I want more time to be given to the next presenter. So I welcome once again to our next speaker, Miss Priya, who will also enlighten us on a global perspective on adolescent. So I welcome once again Priya to start her presentation.
Thank you, Mr. Kapse. Hi, Rushi. It was nice, a very informative session from your side. And good morning to everybody from here in Canada. My name is Priya, and I'm a social worker here. I have been working with the school board, especially the district school board in Ottawa, the city where I live, which is part of the state of Ontario. So I just want to know how are we going to do the presentation? Do I share my own this thing, or is Vikas going to do it?
Ma'am, you can share.
Hello, can you hear me?
Yes, ma'am.
Can you bring up the slides? Okay.
Okay.
And you want me to share? I can share the screen. I can share my screen with you.
Yes, ma'am. You can share, ma'am.
Oh, okay. Sorry, I thought it's the other way around. No problem. I will just. Can you see?
No, ma'am.
Can you see my slides?
No, ma'am.
Oh, hang on. Okay. Oh, here it is. Just a second.
Okay, ma'am. It's visible.
Yes, it's visible.
Oh, okay, perfect. All right. So All right. So the topic, as Rushi has started, it's adolescent mental health global perspective, and Rushi has very given us a Indian picture. I'm very briefly going to give a Canadian picture, and it's not a global. I mean, it's not a national Canadian picture, but it's a provincial one. That is the state where I live in. Okay, so our prevalence rates are like this. That is 1 in 5 children in Ontario, that's the state where I live in, has a mental health challenge. And 5 out of 6 of those children will not receive the treatment they need. And 28,000 Ontario children and youth are waiting for mental health services. For some families, the wait is up to 2.5 years. And one reason probably could be that over here in Canada, the education and health is free. And so, you know, it takes a while by the time the services come into the clients. So that is why one reason is that. The second thing is that Ontario is is the biggest state in Canada. So, you know, combined together. And the third reason is that, as Rushi said, there is lack of awareness about the services and the stigma associated with accessing these services. For these reasons, I think the wait time is so high, 2.5 years, 2.5 years. Imagine if your child is in a crisis right now and is having mental health, you have to wait for 2.5 years to get some services. Yeah, so it's a grim situation here also. And 28% of students report not going, not knowing where you have to go for help. Kind of, I think Rushi also touched upon that in her presentation. I think it just runs across universally. To continue with it, 34% of Ontario high school students, they indicate a moderate to serious level of psychological distress, which means there's a high level of anxiety and depression. And 14% indicate a serious level of psychological distress. 40% of high school students also report of having contemplated suicide in the past year. Now, the study that I'm referring to is conducted in 2018, and the past year, matlab 2017. And the Canada's youth suicide rate is the third highest in the industrialized world, unlike India, which is really high, but because Canada is it's considered one of the industrialized world, and imagine of it being the third highest in the industrialized world. Yeah, and even in India, the rates that Rushi gave, suicide rates 25% in boys, 50 to 75% girls with the issue, right? That's huge. That the numbers are really big. And for us over here, the main issues which come across with children, especially in the school, is anxiety is the highest. I mean, you have a major chunk of students who report of anxiety. ADHD takes on the next position, and depression is the third position. Okay, I'm just quickly going to go through the intervention. So as most of the social workers who are on the platform right now would know that these are the 3 things that we do for intervention. One is assessment, second is formulation, and the third one is treatment planning. In intervention, we have first is intake. Now in intake, what we do is we first see is where is it referred from. We have an intake form, referral form. Over here in Canada, the health system is such that any health concern you have, you first go to your, you have one doctor who is called your family doctor, and you go to that doctor, and then that doctor refers you to the specialist. So for example, if I have a mental health, I go to my doctor, and then my doctor refers me to a psychiatrist. That's how the system is over here in Canada with regard to health. So when we do intake, we first see where is the referral coming from. Then after that, we do the interview with the child and the parent. aspects, right? And we also have, after obtaining consent, we as social workers, we can make observations both at home and at school. And that is basically to see how the child is doing, how, what are the levels of interactions with the teachers, with the other students, is he aloof, or whatever the observations are. And then you also take collateral information, which is information from other sources, like teachers, friends, families, neighbors, if possible. All has to be done after consent. We also use some standard assessment tools for social work assessment. And then social workers here would know all these, that is the developmental history. All these things are taken into consideration. The presenting problems, what is it that the child has actually come to us for, and what are the family and the social history, what is the situation, the parenting style, the interaction, the relationship between the family members, who is the child close to, and basically the whole of that thing. Academic history is the other thing. Academic history, it's how is the child doing in the school? Is he doing okay in studies? If not, then what are the contributing factors? And then the strengths and resilience, because every individual, not only child, but every individual has some strengths. So what are the strengths that the child has? What are his favorite subjects? What does he like? How does he spend time with his family? All those things. And then another contributing factor would be the actual clinical diagnosis, if the child has a clinical diagnosis. Yeah. Then we go to the next stage in intervention, which is formulation. So after having done all this assessment and having collected all this information from all the different aspects of the child's life, we make a initial interpretation, and we kind of make a hypothesis, a working hypothesis, that okay, I think with this information, this is probably what the whole situation is, for a hypothesis to understand why the presenting issues are occurring. And once we have that, then we enter the treatment planning. So for treatment planning, what we first do is appropriateness of services. So if I'm giving a therapy, I mean, if the client is there with me, if the child is there with me, and am I supposed to give therapy or am I supposed to refer? So that is what we would see in appropriateness of services, right? Then in treatment, there is the thing called treatment hierarchy. So which means that all those behaviors which are life threatening, those first need to be resolved, right? Then you go to those behaviors which are threatening to therapy, and then you manage all those behaviors which are threatening to the quality of life. So that is called treatment hierarchy, which is a very important component in treatment planning, because if you don't manage these three, then the success of the treatment is pretty much questionable. Then the next thing you have is a behavior stabilization, which we deal with. This motivation interviewing is a very important tool for client engagement, because it works on the whole thing of via interview. You try to find out the strengths of the child, and based on that you get all your information, right? Then the next thing you do is establishing clinical goals, which social workers are aware of. We develop the goals as to where do you want the client to reach to. Now, I'm using client and child interchangeably because that's how it is over here. And disorder specific psychoeducation is another intervention that we give. Now, I've just divided it like this: in individual therapy, and family, and the common therapies that I as a social worker have given to school children. So in treatment planning, in individual therapy, we generally give cognitive behavior therapy for children who have depression and anxiety. And for those who are suffering from borderline personality, we do a dialectical behavior therapy. Then victims of child abuse, we generally follow the approach of trauma-informed care, which is a huge thing here, because child sexual abuse, or not only sexual abuse, but child abuse is also a very huge issue in this part of the world. Then exposure therapy is another line of intervention for especially for anxiety. Children with anxiety. Then is a very interesting approach, which is collaborative problems. This, like Rushi was saying about the parenting with regard to screen time. I have found that this is a very important approach. It is a very successful and useful one for managing the whole drama which goes around with regard to screen time monitoring. And I'll be discussing this very briefly going forward. When it comes to group therapy, we have a few group therapy programs that we follow. One is called SNAP, which is for 6 to 11-year-old boys, and it is basically for antisocial behavior and those who have been in conflict with the law, and those who have been in touch with the police and things like that. Basically, who are in the opposite of the legal side, right? And then is another program called Coping Cat, which is mainly a program which is focused on cognitive behavior therapy. It is for anxiety and for children between 7 to 14 years of age. And what it has is, it includes education, it has a group for coping skills training, it has another group for gradual exposure to anxiety provoking situations, and then it has another fourth one which is a homework assignment. So with all these things, this Coping Cat addresses the anxiety issues of 7 to 14-year-old kids. Then social skills training groups, which like Rushi said, is picking up in India, which is a very wonderful thing. And then you also have in a group, you do DBT, skill training. Am I going fast? Hello?
Yes, ma'am.
Hello? Okay, am I going fast?
Yes, ma'am, you are.
Okay, fine.
No,
It's
it's okay.
perfect. It's perfect, ma'am.
Okay, perfect. So then continuing with the treatment plan, this is school-based. There is a thing called day treatment centers. Here in Ottawa, we have a center called Robert Smart, which is basically, it provides mental health services through high school and through high schools. Sorry, I'm a bit distracted because there's a knock at the door. And it focuses on prevention. And it's basically through the school. The referral has to come through the school. And so this NGO works very closely with the school administrative staff, with the social worker and psychologist, right? And then the next one, what we have over here is an option called residential live-in treatment programs. Now, this is also offered by two organizations. One is Robert Smart, and the other one is called Davy Smith. And it's basically for teenagers who have entered addiction and who of course want to give up. And it's a kind of a last resort because it is a residential program. You kind of have to separate the child from the family. So it's not a very it's not one of the first options available. It's kind of pushed to the last. Then the other one is ongoing case management, crisis support, and emergency services. Then with regard to family work, you can do a few therapies here. One is emotion-focused family therapy. And a huge part of school social work has been to coach the parents to bring in some structure and schedule, and to help them in developing reward systems so that they can see some changes in the behavior of kind of a, what you would say, explosive child. And then there's another thing of coaching parents to work with positive reinforcement and to set realistic expectations. So these are a few things we work with in the family. Now, as I was saying, collaborative problem solving in the individual therapy I would be touching upon. So let's see what that is. So this collaborative problem solving is a very interesting approach, which has been, it's actually an evidence-based model of psychosocial treatment, which was developed by Dr. Ross Green, and it's illustrated very well in this book called The Explosive Child. And it's basically based on the premise that kids do well if they can. Okay, so what it says is that rather than focusing on kids' challenging behaviors and trying to, modify them and fix them, collaborative problem solving, it helps kids and caregivers solve the problems that are causing those behaviors. So this has a few steps. So for example, let's take a situation, okay? A 10-year-old boy, girl, whatever, a 10-year-old wakes up, not even wakes up at 12 o'clock in the afternoon. You have to go and wake him up, like literally wake him up. And then he gets up and he's like, why are you waking me up? And, there's a whole bombastic performance there, all anger and outburst and everything. And the mom gives back, hey, you can't talk to me like that, be respectful. The kid talks back, and the morning waking up routine itself is a mess. And then there's no solution to it. Both of them get angry. There's anger outbursts, and then they go their different ways. So in a collaborative problem solving, what happens is that the mom comes down. I mean, this is how we coach the parents, that the mom goes down, calms herself down, and when the kid comes down, why I say down is, sorry, because over here houses are 2 floors and the kitchen is generally on the ground floor. So, okay, so the child comes to the kitchen, and then the mom's very nicely with empathy says that, okay, listen, this is the problem that we have. You getting up at 12 o'clock is not a right thing, because it delays everything further. You skip on your breakfast, right? Then the second stage is where the mom says, I wonder why that's happening. Then you dig deeper and the kid says, oh, because I feel sleepy. Then why are you feeling sleepy at 12 o'clock? Because last night I was on my gadget till around 1 o'clock. I was checking out my Instagram. Okay. So you keep, discussing and probing very gently into what is the issue, and you keep probing till you reach the aha moment. Okay. Then the next step you go in for is, oh, there it is. Okay. Then the next step is you brainstorm. You brainstorm and you kind of find out solutions for the problem. I was just wondering if we can fix this problem. Is there anything we can do to, not get up at 12 o'clock in the afternoon? Maybe you can get up at, at least at 9:30 or something. And then together, collaboratively, the mother and the child discuss on, okay, maybe I can do this, maybe I can do that. In a idealistic situation, as a mom, you would think that the child says, okay, fine, mom, I will sleep by, I'll switch off my gadget at 10 o'clock and maybe we can spend some time together, family time at night, and by 10:30 I can go to sleep at night. So that is, they have brainstormed together, and then you formulate, you bring out the formula saying that, okay, so from tonight onwards, we're going to switch off the gadget at 10, and 10:30 we'll be sleeping off. So tomorrow morning, you can get up at least by 8:30 or 9, right? And you affirm that, okay? And we will do this only if getting up at 12 is, a mundane, not mundane, but a huge task for you. So it's like, only if you kind of explode, then we will use this problem. But generally it is an explosive situation. And this is the whole thing about collaborative problem solving. And this has been implemented very successfully in families, in schools, in group homes, and in juvenile detention centers. Rushi touched upon violence threat risk assessment. I think it's a very important approach that schools should use, especially given given the increased number of sexual violence, rape cases and all that I get to hear from India. But in over here, any kind of threat is taken very seriously. So we have a whole protocol which we follow. I have been trained in this violence threat risk assessment, and it is very well explained in this flow chart. So I'll just quickly go through it. So the whole premise of VTRA is that that the the anger outburst, or not anger, the threat comes not suddenly. It evolves. It's an evolutionary process, and nobody just snaps like that. You know, there is something building up, and then the child says, okay, I'm going to kill you, right? It's suddenly a child just say, I'm going to kill you, right? So I'll give you an example that I had. This is a 10-year-old child. I was called to the school over here in Ottawa. We social workers, school social workers, we have like, we don't sit in one particular school. We have many schools that we have to manage. So at a given point in time, you would have at least 8 schools to manage. So one day when I was in a school, principal from another school calls me and says that I have a child here who has put a cord around his neck and he's trying to, harm himself, but we have been able to use physical force and stop that whole action of his. But clearly there is a threat involved, there's a risk involved here. So then as a trained social worker with VTRA, I go there, and this whole VTRA protocol has to be run by 2 people, a psychologist and a social worker, or the school principal, anyone, but 2 people should be there. And then we sit down and we discuss everything. So the whole thing is, there should be a baseline that you mark, and then after that you see what happened exactly, the when and the why, and the you just dissect the whole situation and dig deeper and find out what happened. So if you feel that there is not a threat as such, it's just anger outburst, right? It's, you don't do anything, but you try to do the anger management, or you try to be careful and keep the child under your radar to see if he's going to do something, and what is he going to basically do about his anger. If it is yes, that you think that it was a kind of threat, he really wanted to, he had the intent to really kill himself, then you go to the next step to see whether there was a attempt to resolve the threat as transient. That is, whether it was a temporary this thing, or whether he really had intentions of killing himself. And by doing that, you basically see how angry, or what was the frustration level. Does the person retract a threat, or offer an explanation or an apology that indicates no further intent to harm himself? Then you if you get an answer that no, then you go to further this thing. You go to step 3, and you take precautions to to see that he doesn't do that. So you have to go and check into his wardrobe and see whether he has anything, any weapons, a knife, or anything which he could potentially use as a weapon to harm himself or to harm anybody. You clear that off, and you do all those things, right? And there are certain levels in this. There is a mild, serious, and very serious. So at this stage, if you get an answer that it is serious, then you you say that it's a case resolved as serious with substantive threat, and you try to refer the child to other services. That is, you could refer the child to a psychiatrist, or to some other therapies which would address this issue. And then if it is very, very, if it goes down further, if it's very serious, then you have you conduct a safety evaluation for a very serious substantive threat. So you have a safety plan in process. You make the plan that if the child has any kind of weapon in his thing, that you make the mother aware that this is what happened. You keep inform the police about it, and those things. You do all those things, and then your follow-up is a huge part, and you monitor the situation of the safety plan. So this is basically this is very, very briefly I have said about VTRA, but the reason why I brought it up is because I feel VTRA in schools in India should be given consideration, and I think this is a very good platform to start a discussion with the government level. I know Rushi is at a position probably to start the discussion. So just to give you a glimpse of the whole situation. Then assist is another thing which is very, very useful for suicide prevention. It is called Applied Suicide Intervention Skills Training. It's a one-day training, and it is basically a kind of suicide first aid or suicide prevention. So if you see, like if you're driving down and if you see some person trying to jump off the bridge, if you're assist trained, which I am, you can kind of intervene there, and even before the police, you get priority. And you can help the person. You can. It has a few steps, and you go through the whole steps of first finding out and kind of motivating him, giving him a reassurance, giving him alternatives, and you kind of basically the whole motive is to not make him jump, right? So this is kind of a quick fix, and then after he hopefully he has not jumped off but has jumped onto the road, and you can then discuss this further and then see what happens, and then make appropriate referrals. And this assist, it teaches participants to work with, it actually recognizes when someone may be at risk of suicide, and it also teaches the participants, that is like people like me, to work with the person who is going to jump off, to create a plan that will support their immediate safety. So I think I haven't given a big exhaustive list, I hope so, but a few approaches which I use very commonly is what I have discussed, that is collaborative problem solving, which is awesome with the kids. Sometimes I have to use it with my own kids, and VTRA, which is a huge thing, and assist, which is very, very effective with suicide prevention. Thank you so much.
Thank you very much, ma'am, for a very, very nice session and giving the account of what social workers are being engaged in activity of delivering psychosocial care. This was a very, very informative session, ma'am, and so many responses from all the participants, so many questions. But I do apologize that we have already crossed the time limit. But however, very important questions have been raised by the participants. So some of the questions that I would like to highlight is to Rushi ma'am is that what could be the areas in which we could focus on the tribal related child and adolescent mental health issues. So that could be a very, very useful for us. Some of the questions also are focusing on what kind of a modules and what would be the reference material for this. So these kind of things are very, very important. So ma'am, if you can briefly explain on this. Hello.
Yes, sir, you are audible.
Yeah. Yeah, is Rushi ma'am somehow left? Hello.
No, ma'am is here.
Yeah.
Hello.
Okay,
Ma'am is
ma'am,
here.
please respond, ma'am.
Hello.
Yeah,
Yes,
ma'am.
yes,
Yeah,
please.
please respond.
Yeah.
Yeah.
Yeah. So what can you just repeat what you were saying? I just left
Ye-
for a while.
Yeah, ma'am, we are looking for what kind of modules that we generally use, and the another very important question is that the regarding the tribal, child and adolescents, what could be the mental health programs and what could be the interventions that we could, go for a larger kind of, scale, because a lot of areas in the country has dominantly tribals, so what could be the areas we need to focus and assess and then plan the intervention, please ma'am.
See, like I have discussed in my presentation about the life skill training program, which is a mandatory program by the CBSE board, by the government of India also, that should be imparted in all the schools, whether they are the government school or the private school. So the scenario of Delhi, as I have told that there are about 2,000 schools, and nearly in about there is only 10% schools are having counselors, right? So as because there is shortage of the mental health professional, there is shortage of the psychologists or counselors in the school. So it is not possible that the psychological issues or the mental health issues can easily be dealt by the health professionals. So what happened in that scenario, that we have to put a lot of focus on the promotion of mental health. Like I was talking about the life skill training program. So these are the programs which can be imparted by a certain group, which can be imparted by the teachers, or nowadays there is a concept of peer education. So there, we choose some leaders from all the classes. I mean, I'm talking about the adolescent group. So generally we pick up 9th, 10th, 11th or 12th. So there will be 2, 3 or 4 students from each class which are being picked up. You train them into, to train other people, other kids in the school for the social skill training program. So this is a holistic approach. This is a comprehensive program where, decision making, problem solving skill, negotiation skills, communication skills, IPR, interpersonal skills all get improved. Like I have said that there are like bullying and all these things, violence, these are the very big challenges nowadays in the schools, in the adolescent group. So what happens that by developing or by imparting these programs among the kids, first of all, there is improvement in their coping strategies. They know. So when we talk about bullying, what happens? Usually what happens that they choose always a vulnerable child. The bully always select a vulnerable child who will easily be affected by the comments or by that, act of bullying. So they have if they have already been trained in life skill training, or they know how to deal with, so it's not always advisable to give or to respond to what the other people in the classroom are saying. So the communication skills or the interpersonal skills are very important that way. So a lot of issues, a lot of violence or aggressive issues, or many other behavioral issues or emotional issues can be dealt very easily by this life skill training program. The most important problem nowadays in India, in each school, whether the schools are in rural area or in the urban area, whether they're the government school or the private schools. So adolescents are having problem in to basically to regulate their emotions. So like Priya was talking about that, they go for DBT. So DBT is a very technical thing. It's a therapy. It's a kind of psychotherapy which can be imparted by the clinical psychologist, or if sometimes by the trained psychologist too. But as we don't have the human resource in India, so we cannot deliver all those services till the time the adolescent is not being referred to the healthcare providers. So in that scenario, if we have, focusing on this comprehensive program of life skill training, then automatically they will learn how to regulate their emotions. If you will see in school going children, or in school going adolescent, or college going adolescent, all the parents, all the teachers, they just report that, these kids, they don't know how to regulate their emotions. So there is lack of self-awareness. So by developing this program, and like that, there are many programs for happiness also. If we can train the person, if you can train the adolescents where they can, recognize their emotions, they can get awareness about their emotions, and they know how to regulate their emotions. So they may feel happy. So it is also an art which can be departed by these programs. So these programs are very useful. And like I was talking about the mindfulness training program, so why we have given so much focus on that training program? So first of all, in all over the world, it is a mandatory program in all the schools. In India, this is not mandatory, but we can give a proposal to make it a mandatory program, because it not only beneficial for the enhancement of their attention concentration or their academics, it plays very important role to regulate their emotions. So it enhances their cognitive or academic skills, so they can manage their academic related stress in the classroom. Or so it is important for the overall holistic development of the adolescent. So that is the
Yes, ma'am.
reason.
Yeah, thank you very much, ma'am, for answering this. I have another one question. I think we are out of time, but it's very important that a social worker and a psychologist work in a very holistic manner. So one of the issues that Priya ma'am has highlighted, that a collaborative problem solving, which can be very highly used. So another question to you, ma'am, Priya ma'am, that how we can work or use this collaborative problem solving in a larger community setting. But as ma'am has rightly pointed out, that we have a very less human resource working in India on particularly on mental health. So how do we go for a school, community based school mental health program? So I think that could be the very useful. Priya ma'am, please.
Hi. So your question is how you can use collaborative problem solving in a community based setting. Is that what you're asking me?
Yes, ma'am. Because looking at a very large population. Yeah. So how do we go about it? And yeah.
So collaborative problem solving is a individual this thing. It comes under individual. Unfortunately, you can't do it. I don't think you can use it for a community or a group setting also, because it has to be one-on-one. I feel so. I do not know whether you can, I haven't come across studies where it can be used for a group, but maybe we can formulate something and see the success of it. I don't know, but it's mainly individual this thing which has been successfully used as parents, as teachers, so it's mainly and it's a part of the CBT, so it's an individual CBT, I would say.
Yeah, thank you, ma'am. Thank you for indicating. I think Rushi ma'am also wanted to speak. Hello.
Ma'am, unmute yourself. Rushi ma'am, unmute yourself.
Yeah.
Yeah, ma'am. Very
No, it's
briefly,
okay.
ma'am. Yeah.
Yeah, you can go ahead. It's okay.
Okay, ma'am. So
if anyone have any specific question from me, then I would like to respond. But otherwise, I think that I have already
Yeah,
And this is
so
which is a very comprehensive one. Yeah, there is no end point by talking on this topic, I think so, because like I have said that it's a very vulnerable age. There's a transition from childhood to adulthood. So many rapid changes are occurring. So there are so many challenges these adolescents, group they face. So there can be a very wide discussion on if we can pick up each and every issue faced by them. So if like we are lagging behind the time, if you have any specific question from me, from the audience, I'm very much eager to respond.
Yeah, ma'am, but my apologies because a lot of questions are there, but right now we are already running out of time. So I think we should conclude this session. So that, but definitely, this platform has brought really a global perspective and experience of working as a social worker back in Canada, and definitely the very informative session by Dr. Rushi, who has focused on various aspects of child and adolescent mental health. So looking at the prevalence ratios which has been mentioned, it is very, very important for all of us to learn from this, to enhance our skills and practice for the betterment of our child and adolescents. So with this session, I once again, I thank you, Dr. Rushi and Ms. Priya, for a very, very wonderful session. I am, I thoroughly enjoyed it, and I do believe that all the participants have enjoyed in such a manner. I also would like to thank you, Dr. Manisha Kiran, who is not only a guide for me, but she has always been highly inspiring us, all of us students, in leading our career and leading our work in a mental health society and deliver the psychosocial care services. So thank you once again, ma'am, for this wonderful opportunity. And listening to all these eminent speakers is very, very highly enjoyable at this evening. I would like to kindly note the participants that this virtual training platform will continue, and the upcoming webinar could have the speakers Dr. Ravi Kishan Jha and Dr. Amrita Sahai. So with this, I would not take so much of time. Thank you once again, each and everyone who has participated and contributed for making this a huge success. I thank you, and I rest the evening. Very good evening and very good weekend to all of us, all participants. Okay.
Manisha ma'am is also there, sir.
Thank you so much.
Yeah, ma'am. Ma'am, if you would like to, say something before we go. Hello.